Now, Lucia, there was one more real-world analysis out of Spain, I believe.
Yes.
Can you tell us about that?
That was an interesting analysis that came from Europe, where she included over 15 centers and had like 156 patients that were majority refractory. Of 90% of them actually were refractory to ruxolitinib. So about 26 were frontline patients, but the remaining of them were salvage well, with a median hemoglobin of 8. So there was something quite unusual. These patients were anemic. And then it was a shorter follow-up of only 5 months, so I wouldn't really take that much of the symptoms control, but they already showed improvements in symptoms in over 60% across different variations.
So,
Symptoms that they took like fatigue and satiety and all of those. And then in a screen for those available, it was what we would kind of expect in the refractory, about between 20 to 30%. So I consider that pretty good, but that was a smaller number because of the follow-up. But a little striking were the anemia responses. So they immediately actually show that the hemoglobin that they started from 8 were like within the first month into the 9 or something. So that tells us, okay, it was really beautifully seen in patient, and majority of them would be actually refractory to drugs. So exactly to this point. And then, of course, this patient did not have a thrombocytopenia, as the median platelets were in the 1/16. So that could be dosed very nicely. But they actually then sliced up and showed the anemia responses in frontline versus refractory. That was both over 50%. In that quick 5 months of media of pretty much very beautiful improvements. So I think that, and then the safety profile was not something that we would not expect. So that was a nice different sentence and kind of very much of a combination using accents, which told us doesn't matter how you approach your patients, it kind of stayed across the different physicians, which is sometimes very important because we have much more patients in the huge academic centers, so we kind of all to know how to handle. But as you said, people will ask, oh, why this doesn't happen because of stuff. And that goes to the point. These patients started with the anemia of 8, so we've seen the nice pickup. But the median hemoglobin had it in 10. I think they would just sustain the 10 and not drop, which is a very important point of. If we treat these patients with the right dose and get it there, as we've seen in the long-term follow-up with momelotinib studies, which had like over 3 years on the sustained treatments, and it was over 800 patients. So that goes along with those data. So I think in the real world setting, it does definitely prove that anemia is very strong driver for why these patients benefit. And that goes in with the excitement and all of our patients feel willing to get on the track. I think we need to learn more about the symptoms of spleen. Here, these different subcategories of patients, whether coming from being out of the drugs, never being on drugs, with from other drug inhibitors. But from the point, it is a very important endpoint on which the drug was approved. Yep. And it does comes with improvement of fatigue and some on the symptoms that these patients suffer a lot. So excellent drug for ambulatory setting, quality of life, and all of the package that these drug inhibitors offer to these patients.
And also, as you just said, sounds like in this large real-world experience, the spleen response was as good as momentum. So that really validates that.
Yep.
Now along those lines, obviously we all know and agree that momelotinib is good for anemia, but it can be made better. And there is going to be a study combining it with luspatercept. It's been given the somewhat poetic name of Odyssey. Well, these have all been odysseys, right? If you think about the journeys of momelotinib, pacritinib, and fedratinib, all have been sort of odysseys. But this is a trial that we're going to be participating in of momelotinib plus luspatercept. So hit the the hemoglobin pathway in two different ways at 2 different steps, downregulate hepcidin and trap these activin receptor ligands. So in 2 ways, try and augment that hemoglobin response, and this is going to be in transfusion dependent patients. Well, we can probably go on and on, but we do have to get back to ASH, don't we? So we'll probably conclude it here, but thank you so much, all of you, for all your input and the lively discussion.
Thank you so much.
Thank you so much.